Lenny, our topic today is revision stapedectomy. We've already discussed the topic of selection for revision, so let's talk a little bit about revisions themselves. Our first pearl is, do not do a revision in less than 2 or 3 months. In the earlier days of stapedectomy, it was very popular that if the patient was dizzy or that would use tuning forks and weren't happy with the tuning forks, the patient wasn't hearing well, that early revisions were in order. And that was especially in the days of gel foam, I think. But there were so many revisions early on. I myself did many revisions early on because that was the thing to do. And I don't remember one case, I really don't, that I ever revised in the first month or 2 months that I was able to help. First of all, it looks like a jungle in there. You cannot tell any anatomy. The place is just a mess. The middle ear is just a mess. In the first 2 to 3 months, there is no reason to revise. I don't care whether the patient is dizzy or not hearing. There's just no reason to do it, and you're not going to help them by going in. So stay out of the ear. We know that. Our indications, I'm going to repeat a little bit. You should have at least a 20 to 25 decibel air-bone gap. The patient's discrimination must be at least 75% if they have a moderate loss. You're not going to get anywhere revising an ear, where you've got a 25 decibel air-bone gap and a 70 decibel loss and a 40% discrimination. You're not going to help that patient. Also, your tuning forks must make sense. Either you need a negative Rene or at least a Weber that lateralizes to the ear you're going to be doing. The first thing we look at, or that I have looked at for years when I go into a revision ear, is whether or not I have to curette. That tells me how good the surgeon was who preceded me. If I've got to do any amount of curetting that's of importance, then I know that I'm following an inexperienced surgeon. The second thing I do is to test the malleus, and I test the malleus every time with the same blunt, strong instrument. I lean it against the malleus, and if there's, as we know, if the malleus slightly moves or moderately moves or is almost fixed, it doesn't make any difference. You're going to get a good result. Or that is, the malleus is not the problem. It's only the totally fixed malleus where you can lean against it and it doesn't move. That's the only one that we're concerned about. Let's discuss an old topic and a short one, and that's revision of the posterior cruce technique. As you can see by the diagram, the surgery that was done was where the patient had an anterior focus of disease. The surgeon would separate the anterior from the posterior portion of the foot plate, leave the anterior portion alone, and then slide the posterior cruce around to the posterior part of the foot plate. Jack Huff was a master at it, and he did a great job, but I don't think many people could reproduce his results. And I revised a lot of this technique earlier in my career, and it's the simplest revision there is, because all I would do would be to take off that superstructure of the stapes, put a vein graft down, if the foot plate was moving. If not, remove that portion, that posterior portion of the foot plate, and then put down a vein graft and a piston prosthesis, and it's easy to get a good result. It's a simple revision to do. The piston prosthesis presents, like every prosthesis, certain problems. I think the main problem is caused by the retraction of the tympanic membrane in its posterior superior segment, or where we have a thin tympanic membrane to begin with. And there we can get an erosion, of the prosthesis right through, can come out right out the drum. I've had a lot of them do that because that drum just retracts down and, of course, pushes the prosthesis up through. And there, of course, we deal with an eroded incus, and we talk about that in a separate segment. And, of course, we must be prepared to repair the drum either with perichondrium or fascia, probably perichondrium, so that we won't get that kind of retraction again. The next problem I'd like to discuss is ankylosis of the piston prosthesis to the incus. This is a problem that develops 2, 3, 5, 10 years after surgery. And the patient slowly develops a conductive loss. And as you can see by the slide, what happens is there's an actual ankylosis of that prosthesis to the lenticular process, and the prosthesis is pushed out of the oval window area and onto the promontory or somewhere else. We used to do all sorts of cuckoo things to try to repair this, because in some cases you just can't get that prosthesis off. And where we couldn't get it off, we would put down a Bailey prosthesis from that incus down to the foot plate. We would come up with all sorts of Rube Goldberg things. Now, since the laser, it's easy, isn't it? Because we simply laser off the prosthesis, and we put a lippy prosthesis on, as shown in the next slide. So this next slide shows the prosthesis lasered off of the incus, and then the lippy prosthesis placed on, and this works out very well, doesn't it? Why don't you discuss some of the wire problems?
Bill, the Teflon wire prosthesis has been used a great deal over many years. It's an excellent prosthesis. However, the lenticular process and the distal process of the incus are susceptible to loss of blood supply if this wire is too tight in that area, and it can lead to necrosis. So we have seen many cases where there's prosthesis malfunction along with incus necrosis because of the wire problem at the distal long process of the incus. And on expiration, once we verified that the malleus is intact and mobile, and sometimes we need to rotate the bed away in order to see that and also palpate the malleus, we will then inspect that critical area of the incus prosthesis junction. And if we verify that there is an erosion at that junction, we will try then to move the wire prosthesis aside. And the great advantage of doing this with the patient under local anesthesia with sedation is that we can monitor their dizziness. If they are dizzy on 2 or 3 attempts while we do this, we will not pull it out. Rather, we will set it aside as demonstrated in this diagram. What you see here is that the wire has been taken off the distal long process of the incus, but the Teflon portion or the medial wire portion in the neomembrane has been left alone because it would be too dangerous to remove it if the patient has dizziness. So we push it aside. And what we can do in our reconstruction is leave that prior prosthesis in and cut a slit in our new vein graft to accommodate it, and place a new vein graft down with a bucket handle prosthesis. If the incus and lenticular process are adequate, we can use the classic Robinson prosthesis. If there's damage at the lenticular process or the distal long process, we'll use a modified lippy of various lengths.
Of course, in many of our cases, that dizziness is not a problem, and the prosthesis is loose either at the incus end or at the oval window, and it's simply a matter of removing it. And you're talking here about where you better be careful removing it because it's still attached, and you don't want to do a labyrinthectomy or a partial labyrinthectomy. And that's why we want to know if the patient is dizzy. What's the main thing we see in stapedotomy?
Stapedotomy, made and created with a diameter of approximately 0.6 millimeters, is becoming more and more popular, especially over the last 20 years, with concerns of side effects from total stapedectomy. However, for us to assume that a prosthesis can be placed in a very small stapedotomy opening and stay there for long term may not be always necessarily so. Mechanically, as the prosthesis moves, it may just come out slightly or hit the very edge of a thickened footplate, and the patient can have a subsequent conductive hearing loss. So in our revisions, when we explore an ear and we see a prosthesis that's not moving well, we take down its connection to the neomembrane area, and we often find a great deal of footplate left, and this prosthesis will not be in the neomembrane but rather adjacent to it. So we will remove that and then proceed with a partial stapedectomy, focusing on the posterior footplate to remove it, setting down the vein graft and our prosthesis.
Let's talk about what you're going to find when you're looking for a fistula. I've found a large number of large fistulae throughout my career, and I found a fair number of small fistulae. It's another advantage with the patient awake, because you can have them bear down. Now you got to be very careful when you make the call of fistula, because you know there have been eras we've gone through where almost everybody had a fistula. The rapidly progressive sensory neural loss. There have been different eras in my career where fistulae have become were very important. They're not as important today. So you know, if you look into an ear and you see fluid accumulating, doesn't mean a thing. I mean, there's just a certain amount of tissue fluid that's going to accumulate. You've got to see fluid coming from one place, and you know, it's got to change the light reflex on your microscope. It has to do something dramatic for you to confirm a fistula. Once you find it, of course, the repair is easy. You cover it with a tissue graft. The interesting fistulae that we've had with the piston vein technique is that they've all occurred in the same kind of patient. We have 6 of them on our computer. They were all in women, and if you can assume that women have smaller veins than men, it means that their vein graft was probably a smaller or thinner graft than you would have gotten on the average man. And they all occurred on descent, and they all occurred where the facial nerve was uncovered. Now we talk about removing the mucosa all around the footplate area before we put down our vein graft, and we do that to get 2 adhesive surfaces. Now, before I came to the realization of what was happening, I didn't take the mucosa off some of the dehiscent or exposed facial nerves, so there was no raw surface. And all 6 of these fistulae occurred not under the piston, but over the area of the facial nerve where the vein had kind of moved across. You know, it wasn't adhered to the facial nerve, it moved across, and there at the junction of the oval window with the facial nerve is where these 6 fistulae were. They were all conductive, by the way, and they were all repaired successfully.
Do you think that if you take a larger vein graft in a female with a dehiscent facial nerve, this will prevent that potential problem?
Well, we try to get, as you know, a large vein graft in everybody. I think we talked about in another section, we don't take the vein graft from the hand. It's too difficult to work with. So a vein graft taken from this portion of the arm is the vein graft to take. You want to get the largest one you can. Mm-hmm. In your revision, use a tissue seal. We use a tissue seal with a piston prosthesis. And maybe I'd like to end this section with John Shea's famous one-liner, use a speculum holder.
In your revision surgery, we highly recommend you use a tissue graft, preferably a vein.
Lenny, let's finish this section by stating what we call our surgical directives. Do not reoperate or revise before 2 or 3 months after your initial surgery.
Secondly, do not revise sensorineural hearing cases unless there's associated dizziness.
Do not revise a footplate that was obliterated originally. It's going to be obliterated again, You drilled it out the first time. You're not going to have a good result if you have to drill it out a second time.
Do not reopen the oval window neomembrane without use of the laser.
We strongly recommend intraoperative audiometry.
All patients should be operated under local anesthesia with sedation so that you can monitor their dizziness.
Do not do revision surgery unless you're familiar with and able to use the laser.
If the patient is dizzy on manipulating their prior prosthesis, leave it in and push it aside. You can still continue with a reconstruction revision.